Thank you so much, Tashina. Thank you for having me. It's a wonderful opportunity to partner with Philadelphia Fight, and I have a lot of things that I want to share with everyone today. So I'm just going to jump right into it. Okay, so, Okay. So first, let's start off talking about HIV, human immunodeficiency virus. From my understanding, my audience today is a mix, right? So persons who are living with HIV, care providers, social workers, people who just want to learn more about HIV or pregnancy or both. So I'm going to bear with me if you are very knowledgeable already about HIV, because we're going to start with the basics. So HIV is a virus that attacks a person's immune system. When our immune system becomes compromised, we lose our ability to fight off illness and infection. And then AIDS, acquired immunodeficiency syndrome, is the name of the life-threatening disease that people with the HIV virus may develop. And they are diagnosed with HIV if they have one of the infections that are connected with HIV. We'll talk about those later. Or if all of their blood tests show that their immune system has been badly compromised by the virus. And we'll go further into that as well. So HIV can be transmitted from person to person when certain body fluids go from the person with the infection into another person's body. And those fluids consist of blood, semen, vaginal fluids, or breast milk. There are three main ways that this can be done. So by having unprotected sex, by sharing needles, and from the mother or birthing parent to the child at birth, or through breastfeeding. HIV is not transmitted through casual contact. So let's talk about some numbers. In the US in 2018, almost 38,000 people received a new HIV diagnosis. From 2014 to 2018, the diagnosis increased 7% among adults and adolescents. And at the end of 2018, over 1 million people had HIV, and 6 out of 7 were aware. So that means 1 out of 7 did not know that they had HIV. But it's important to note that a person with HIV who takes their medicine as prescribed can get and stay virally suppressed, have their levels undetectable, and they can stay healthy. In the Philadelphia region, there are an estimated 30,000 people living with HIV, and Philadelphians are being infected at a rate 5 times the national average, and at a rate more than 50% higher than residents of New York City. So let's talk a little bit about diagnosis. So there are a multitude of tests for HIV. I'm just going to talk about 2 of the more popular ones. They detect the HIV antibody or antigen. So an antibody is a response. They are a response from your immune system that protects you from a virus. And we're going to talk about the ELISA and the Western blot. So ELISA stands for Enzyme-Linked Immunosorbent Assay. And that is the screening test, and the Western blot is the confirmatory test. But first, I want to just mention some numbers or evaluation tools that we use when we're looking at tests and which tests we want to use. So the sensitivity of a test is the ability of that test to correctly identify people with the disease. So a high sensitivity gives you a true positive. Specificity is the ability of the test to correctly identify those who don't have the disease. And that can give you a true negative. Now that comes into play when we're talking about the screening tests and the confirmatory test. So the first one, ELISA, Enzyme-Linked Immunosorbent Assay. It's a screening test that detects the antibody, and it becomes positive 1 to 12 weeks after infection. Now, this one has a sensitivity that can vary from 93 to 99%. And what that means is that a negative ELISA essentially excludes HIV as long as the patient has not had an exposure right before testing. And then the specificity is high at 99%. So if the screening test, the ELISA, comes back positive, the Western blot test should be performed for confirmation. Although rare, a false positive ELISA can occur. So you get a positive ELISA, you want to confirm it with the Western blot test. This test identifies the presence of the HIV core, kind of the body of the HIV, and envelope antigens. So antigens are particles that are on every cell in our body. They're also on viruses and bacteria. And your body, your immune system, detects antigens and determines whether or not they are yours or they belong to something else. And if they belong to something else, your immune system will respond and attack. So the sensitivity of this test is 99%, and the specificity is 98.5%. A false positive of the Western blot is extremely uncommon. It's a very accurate test used to confirm a positive ELISA. And both of those tests together yield a sensitivity and specificity of over 99%. So very accurate, and that's what we want to see. So then once someone has been diagnosed with HIV, their care providers will use blood tests to follow the progress of their infection, whether or not they are virally suppressed, whether or not the virus is increasing, and that's known as HIV serology. Those are the blood tests. So one of the ones that we use is CD4 cell count. The CD4 cell count is the best indicator of the status of the immune system and the risk for opportunistic infections or infections that can occur when the immune system is compromised, and also the risk for disease progression. It's used to determine when to start and assess response to antiretroviral therapy, and also for prophylaxis for some infections. If a person is untreated, their CD4 will decrease at about 50 per year. If it's greater than 500, it's unlikely that they will have HIV-related illnesses and their immune system will function as it should. Once they get down to 200 to 500, there's an increased risk of HIV-related problems, but they still may be asymptomatic. But at less than 200, most opportunistic infections can occur, and they should be started on some prophylaxis. The second blood test that we monitor is the viral load. The HIV-1 RNA levels. So this is used to assess response to and adequacy of the drugs, and it provides information that is complementary to the CD4 levels. So it just gives us a little bit more information. The CD4 tells us how our immune system is responding. The viral load tells us how much virus has replicated in this person. So if the viral load is still greater than 50 after 4 months of treatment, that means that the treatment is not effective, and the person should talk with their provider about changing their regimen. But they shouldn't stop their therapy even if the viral load is undetectable for many years. And the reason why is because the virus can hide basically. There can be latently infected cells, and the virus can reappear once therapy is stopped. So you measure the plasma or blood RNA levels of the HIV and CD4 cell count at the time of diagnosis, and then every 3 to 4 months thereafter. So it's really important that even once a person is diagnosed and begins treatment, that they continue to have follow-ups with their provider every 3 to 4 months. Let's talk a little bit about the course of the disease. So the infection with HIV results in a chronic progressive disease. Again, if the person is being managed appropriately on medication, they can have a very healthy life. But without medication, it is chronically progressive, or if they are inadequately treated. So seroconversion, which basically means that they now have HIV. It typically occurs 3 to 14 weeks after exposure, but it can actually take 6 months or more. And in 90% of cases, it's associated with a mononucleosis-like syndrome. When I was growing up, they called it the kissing disease because it could be transmitted through saliva, but the symptoms of that are very weak, almost flu-like. So the person just feels, sometimes they'll say just crappy, you know, just fatigue, very tired. It also can be associated with aseptic meningitis, which is an infection that reaches the brain. So once the virus has been acquired, the patient enters an asymptomatic period, meaning that they could not have any symptoms for quite some time, but they still have the infection. There's a gradual destruction of cells in the immune system called the helper T4 cells, and that leads the person living with HIV susceptible to opportunistic infections as the CD4 cell count decreases. So as I mentioned, typically the person is asymptomatic. They can have lymphadenopathy, which means that their lymph nodes, like when someone gets sick with a cold or something else, and the lymph nodes start to enlarge. That's called lymphadenopathy. So that could be the only thing they have. Then they would develop symptoms like the mononucleosis, like those are called constitutional symptoms. So anorexia, fever, weight loss, diarrhea. They could have some nausea and vomiting. And then as the disease progresses, they could have the opportunistic infections, secondary cancers such as Kaposi sarcoma and non-Hodgkin's lymphoma, or they could develop neurologic disease because the HIV virus also attacks nerve cells, and so they can have dementia and neuropathy. This is just a list of some opportunistic infections. We're not going to go over them, but just so you have an idea of what I mean when I say opportunistic infections. These are infections that if exposed to and you have a normal level of CD4, your immune system is not compromised, your body could potentially fight off these diseases. But with a compromised immune system, it's much harder. And so that's why they're called opportunistic infections, because they take advantage of the opportunity because there's a low or compromised immune response. So the average time from infection to the onset of AIDS in adults who are not receiving adequate therapy is 10 years. When do we consider the person living with HIV to have AIDS? That depends on them having either been identified as having an indicator condition or an AIDS defining illness, and I'll show you a list of those, or they are HIV-1 seropositive with a CD4 cell count lower than 200. So this is a very extensive list of the AIDS indicator diseases. It includes some of the opportunistic illnesses, but then some other. Again, they are ones that typically you can fight off, but with AIDS, your CD4 cell count is low. It's less than 200, and you have a more difficult time fighting these off. So I'm just briefly going to mention treatment. There are lots of medications that are now available to treat HIV, and just an extensive list. But I want to talk about heart therapy. It's the one, it's what is most prominent now and most effective. HAART stands for highly active antiretroviral treatment. Previously, one type of drug would be given to a person living with HIV in order to treat them. But what we found was that HIV virus mutates, so it changes, and it can actually become resistant to the medication. And so what HAART does is it uses 2 or 3 drugs instead of 1. Now, companies have combined the drugs so that a patient can possibly only have to take 1 pill, but it's actually 2 or 3 medications within that 1 pill. And that helps to control the infection because each drug works in a different way, stopping the HIV from replicating itself in different steps, and it decreases the chance of development of resistance. So with HAART, we have had a great response, and as I said earlier, it has proven to be very effective, and those living with HIV can, if they have appropriate therapy, can live healthy lives. When do you start antiretroviral treatment? That's something that is a discussion between the patient and their provider. But I will say that those who are elderly or children, or if someone is pregnant, they'll want to start even earlier. So, or if they have some other medical issues. So if you haven't started HAART therapy, I would talk to your provider to see when they would recommend that based on your entire medical profile. So let's talk about HIV and pregnancy. So about 25% of all persons living in Philadelphia diagnosed with HIV are female. HIV continues to disproportionately affect Black and Latina women who represent 77% of those females living with HIV. So it's recommended that providers routinely screen all women ages 13 to 64 years for HIV, and screen women for HIV during each pregnancy to prevent vertical transmission of HIV. Vertical transmission is when the virus passes from the birthing person to the fetus or the infant. And this screening also goes for trans women as well. So they should also be screened. And screening should occur more often if a person is of higher risk. So between 2011 and 2015, there were a total of 315 perinatal exposures. So the birthing person had HIV during the pregnancy. And that resulted in the birth of 5 infants with HIV in the city of Philadelphia. And so we consider that a good response, although we would love to, because it is low, but we would love to see it be 0. And that low number is due to the local perinatal prevention efforts from various organizations. We have great work that's being done in this city. So what are the concerns of HIV in pregnancy? Well, fortunately, pregnancy does not appear to accelerate the course of HIV. Although pregnant women may be at an increased risk for developing infectious complications during pregnancy. That includes opportunistic infections, postpartum infections. So after delivery, women are more susceptible to an infection. Urinary tract infections increase during pregnancy. Sexually transmitted diseases. Pregnancy actually increases the risk of acquiring a sexually transmitted disease. But there's no direct detrimental effect on the perinatal outcome. That's been noticed. There's no increased risk for growth restriction or low birth weight, preterm labor, or premature rupture of membranes. However, in children, the disease progresses more rapidly. Of infants infected with HIV, half will develop AIDS in the first year of life, and 85% will develop AIDS by age 3. So children have a poor prognosis, and the average survival time from diagnosis beginning 3 years. So that's why it's really important that we address perinatal transmission and try to prevent it as much as possible, because it can be very detrimental to the child. Without HIV treatment, the risk for transmission from the birthing person to the infant is between 20 to 30%. And it accounts for 99% of HIV infections in children. So if we can continue to decrease perinatal transmission, we will get rid of 99% of HIV infections in children. And it can occur antepartum, which is during pregnancy by crossing the placenta. Intrapartum, so that's once the birthing person gets to labor and delivery, and then postpartum. So it's suspected that more than 50%, so more than half of the transmissions occur near the time of or during labor and delivery. So we want to be extra careful during that time to try and prevent that from happening. So some of the ways that perinatal transmission can happen and that we need to take note of in caring for persons living with HIV during their pregnancy is invasive procedures. So amniocentesis, chorionic villus sampling, and umbilical blood sampling are ways to test the health of the fetus while still in the womb. So they're invasive because instruments have to go through the uterus to test the fluid or the umbilical blood. And in that invasiveness can cause transmission of HIV, or scalp electrode placement that happens during labor. Sometimes if the fetal monitors don't seem to be picking up the baby's heart rate, clinicians might put an electrode on their scalp, and it's just like a little prick on the scalp, but it still increases the risk of transmission of HIV. So we avoid that during labor and delivery. Also, the risk is increased if the birthing person has advanced disease, or if they have a recent HIV infection. Also, preterm delivery and some other things that can happen during labor and delivery that I'll mention in a few. So we want to be careful with those. And then breastfeeding. In 1996, HIV medication was known to be safe and effective in pregnancy. And in 2006, the standard of care was to test all pregnant persons for HIV as part of routine prenatal care. A pregnant person infected with HIV can be given medications and take other steps that can reduce the risk of passing HIV to the baby to less than 1%. So that's from 20 to 30% risk down to less than 1%. So that's phenomenal. So we know how to do it. In 2016, only 44 infants were born with HIV infection in the US, and the estimated incidence of perinatal acquired HIV infection was 1.1 out of 100,000 live births. So what are the recommendations? So universal prenatal HIV counseling and testing, antiretroviral therapy for all pregnant women with HIV. So even if prior to pregnancy, it was determined that she didn't need antiretroviral therapy during pregnancy, the birthing person would be put on therapy. If the HIV RNA levels are greater than 1,000 copies per milliliter, the birthing person will be scheduled for a cesarean delivery, and that is when a surgical procedure is used to remove the infant from the womb to bypass vaginal delivery, which has an increased risk if the RNA levels are greater than 1,000. Also, it's recommended to provide the infant with antiretroviral therapy and avoid breastfeeding. So in summary of that, preventing parent-to-child transmission of HIV is one of the biggest public health successes in recent decades. We know how to decrease this risk, and we just need to get the word out and get people in treatment. Every perinatal HIV transmission is preventable, and it represents a missed opportunity, such as getting people connected with medical services, behavioral health, and social services. So screening for HIV is really important, right? If we need to catch HIV in pregnancy to prevent perinatal transmission, then we need to screen. So in pregnancy, as I mentioned, all pregnant persons are tested, and it happens at their initial prenatal visit. So the first time they come in, they get tested unless they refuse. Before it was, you had to get consent for an HIV test in pregnancy, and now it operates by an opt-out. So a person can refuse, but it's part of the panel. It's not something separate, just as they check the blood levels for STDs, all of the tests that happen on that initial visit, HIV is one of them. And it's not just given to certain people. Partners of pregnant women should be encouraged to also undergo HIV testing if they don't know their status. And for those who are considered high risk, if their initial test comes out negative, during they have a second testing during their third trimester before 36 weeks. So screening of HIV on labor and delivery. So if a woman or a pregnant person presents in labor and they haven't had care, or they had care but they didn't get their third trimester testing, they'll receive what's called a rapid HIV test. And that's offered to pregnant women or birthing persons if their HIV status is unknown when they get to labor and delivery. And if that rapid test is positive, they will begin Zidovudine or AZT prophylaxis, and also send off for a confirmatory test. If HIV testing was not done before or during labor, say the birthing person had the baby in the ambulance or in the car on the way to the hospital, and there's no record of HIV status, then it's postpartum, and they'll have an expedited HIV antibody test immediately, or their newborn should undergo testing. And if the results for the mother or the birthing person or the infant are positive, the infant will be started on antiretroviral drugs immediately. And the mother should not breastfeed unless the confirmatory test comes back negative. So let's talk about clinical management. So the person with HIV during their pregnancy will have routine prenatal care, just as everyone has. But in addition, their viral load and their CD4 count will be assessed monthly when starting a new medication regimen, or if there is a change in their viral load. If their medication regimen is stable and their virus load is suppressed, they can, instead of having it checked monthly, they can have it checked each trimester. So a trimester is 3 months during the pregnancy. So they would have it checked during the first 3 months, the second 3 months, and the third 3 months. Vaccinations can be given as needed. Recommended are the pneumococcus, the flu vaccine, hepatitis B, and also hepatitis A for people who also have chronic hepatitis B. And if hepatitis B co-infection is there, that person will also need to have their liver enzymes tested 1 month after starting antiretroviral drugs and every 3 months thereafter, just because the medications can increase the risk of damage to their liver, and if they already have hepatitis B, that further increases their risk. Something that's really critical during the pregnancy is case management. Coordination of services is essential to ensure that the person living with HIV remain active participant in their care and that they're able to adhere to their drug regimen. So that service load consists of prenatal care providers, primary care providers, HIV specialty care providers, also mental health, substance use treatment if needed, and also public assistance programs if needed. A lot of organizations that care for persons living with HIV have case managers that can help with the coordination of services, and it's so vital. So if you are a person living with HIV or know someone who is, and they are planning a pregnancy or are pregnant, talk with them about case managers because it's so important to their care. Providers will use a multitude of agents to minimize the development of drug resistance, as I mentioned with HAART. And unless it's contraindicated, unless there's some medical reason why the person cannot take it, AZT or Zidovudine should be part of their regimen in pregnancy. Antiretroviral drug classes that are currently used in pregnancy include NRTIs, NNRTIs, and protease inhibitors. As I mentioned earlier, there are several different types of medications that attack the virus in different steps. One common regimen is Zidovudine plus lamivudine, or Combivir plus lopinavir and ritonavir, which is Kaletra. But there are a ton of regimens. So just talk with your provider about which one would be best for you. In addition, with the nucleoside analogs, the person will need to have their liver enzymes and electrolytes monitored in the 3rd trimester. And if they're on protease inhibitors, those can cause high blood sugars. So the individual should be screened for gestational diabetes at their first visit, and also at the usual time when all pregnant persons get tested for gestational diabetes at 24 to 28 weeks. And when the CD4 count is 200 or below, they should be started on prophylaxis against some opportunistic infections such as PCP, Mycobacterium avium complex infection, or MAC, and others, typically started on Bactrim, trimethoprim sulfamethoxazole. It's safe in pregnancy, and it is the first choice for PCP prophylaxis. So as I mentioned, the risk for transmission to the infection to the infant increases with the birthing person's HIV RNA concentrations, and a therapeutic goal to keep the viral load either undetectable or less than 1,000 copies per milliliter. In general, the birthing person should be kept on the same antiretroviral therapy that they received before they became pregnant, if they're already on therapy. And if a part of their regimen, there are some drugs that are contraindicated in pregnancy, so their regimen may need to be altered, and they can discuss that with their provider. Again, we want to avoid invasive procedures, and the birthing person should be counseled on the risk of infection to the newborn and their delivery options. So if their viral load is greater than 1,000, so that's high, it would be recommended that they have a cesarean delivery. Usually around 38 weeks to avoid chance of labor or rupture of membranes, which can increase the risk. If they're on therapy and their viral load is less than 1,000, they have a low risk of transmission. They can be offered a vaginal delivery. But again, you still want to avoid procedures that can increase the risk. So don't rupture their membranes. Don't use a fetal scalp electrode. Don't do fetal blood sampling. Try to avoid forceps or vacuums, and an episiotomy. So an episiotomy is a surgical incision that can be made at the base of the vagina, between the vagina and the anus, to provide more room if the birthing person is having a difficult delivery. It's less common now, but it should absolutely be avoided in persons living with HIV. Once the membranes do rupture on their own, labor should be augmented with a medication known as oxytocin, which can increase the strength of the contractions and decrease the time between the membrane rupture and delivery, which can decrease the risk of transmission. So intrapartum care, so when the person gets to L&D, regardless of whether or not they are going to have a C-section or a vaginal delivery, all birthing persons should continue to receive their medications as prescribed. But when they get to L&D, also they will receive Zidovudine through an IV after the onset of labor, or if labor hasn't started but their water broke, until the delivery, or at least 3 hours before their C-section. They need 3 hours before. And they should also continue those other HIV meds on their regular schedule. So this, again, just a reminder not to do invasive procedures during labor. Also, there's a medication called Methergin that can be used to decrease the risk of postpartum hemorrhage. So after a birthing person has a baby, they are at increased risk of bleeding. And there are different methods that can be used to decrease that risk. And Methergin is one of those medications, but it can cause an exaggerated vasoconstrictive response. So the blood vessels will constrict, and it should not be used in people who are receiving a protease inhibitor or efavirenz, because it can be lethal. So for postpartum care, there's several things that need to be considered. The therapy, the drug regimen, reproductive counseling, infant feeding, postpartum complications, and postpartum depression. Some of these are specific to HIV-related care, and then others are not. So very important, again, is to link to care, comprehensive coordinated services, so that, especially for those who did not have it prior, they did not know that they were HIV positive or did not have care. prior to delivery. You want to make sure that they get linked to care. They should have contact with their OBGYN or their midwife within 3 weeks postpartum. And postpartum care should be provided ongoing based on that individual's needs, not just a single postpartum visit, just general. They have specific needs and it should be ongoing. And a follow-up appointment with their HIV healthcare provider should be had within 2 to 4 weeks after they're discharged from the hospital. So for the therapy, it should be continued after delivery. If they have new or continued support services, connections should be made before the hospital discharge. They should have appointments. They should have numbers of who to contact. They should be counseled regarding the potential that during pregnancy, caring for a new baby is a lot. And it could make adhering to their drug regimen, even if they had no difficulty prior, it could make it really difficult. So just talking to them about how they could increase their chances of maintaining adherence, what support systems do they have in place or do they need? And then prior to discharge, they should also be given medications for themselves and for the newborn. And those who have had their initial positive HIV test, as I mentioned, should not breastfeed unless a confirmatory test is negative. If the test confirms the infection, then they should have a full health assessment, including counseling related to the new diagnosis, discussion of the need for lifelong therapy, an assessment of the need for opportunistic infection prophylaxis, and evaluation for associated medical conditions. And again, they really need to be connected to services. When you think about it, this is someone who has a new baby, and that comes with its own stressors and a lot to think about and a lot to do. And now here they have a new diagnosis. So we really want to make sure that persons are connected to services that they need. Also, it's really important to talk to persons living with HIV after they deliver about their reproductive choices. Ideally, this conversation is had during prenatal care, but you do want to discuss it, review it after delivery. Discuss their future plans and timing, the risks and benefits of conceiving on a specific medication. Perhaps if they are planning on becoming pregnant again, they might want to avoid certain medications. Also counsel them on the use of appropriate contraception if they are not planning on getting pregnant, in order to prevent unintended pregnancies. And ideally, they should have that contraceptive plan developed prior to discharge from the hospital. Let's talk about infant feeding. I mentioned several times that breastfeeding should be avoided during pregnancy. So postpartum antiretroviral drugs will lower, but they will not erase the risk for postnatal HIV transmission through breast milk. So in the US, breastfeeding is not recommended and should be discouraged. The benefits of breastfeeding, although there are many, they do not outweigh the risk of HIV transmission. And we have alternatives available here in the US. We can use formula, or we can also do breast milk donation. There are formal and informal ways of obtaining breast milk, and so that option should be also discussed for those interested. However, in other areas of the world, the World Health Organization recommends breastfeeding, and that is because they don't have viable alternatives. Formulas not readily available, it's expensive, and even in some places, if formula was available, the water is not clean, and so we want to avoid that. So the best choice would be to breastfeed. So this discussion should occur during the prenatal period and then be reviewed after delivery. Also, you want to let the parent know that there is a risk of transmitting HIV by pre-mastication of infant food. So some parents like to pre-chew food for their infants, and if they are living with HIV, they should not do that. Infants don't start to eat solid food until 4 to 6 months, but it is something that should be discussed early so they're aware. So what happens when the pregnant person, the birthing person does not breastfeed? Well, they can have symptoms related to breast engorgement. It can be very painful and unpleasant in the days following labor and delivery. So there are some measures that can be used to help relieve symptoms: acetaminophen or ibuprofen for pain control. They can alternate hot and cold compresses on the breasts. They can wear a tight-fitting sports bra. Here in the US, we don't usually give medication to inhibit lactation because of some problems with medications, but there is some recent data that cabergoline may be appropriate for some women. It's a dopamine agonist, ergot derivative, which reduces the production of prolactin, which is important for milk production. Bromocriptine is another medication, but that one is no longer used because it was found to have serious side effects, both for the heart and the nervous system. But again, medication is not usually used, and the birthing person should be able to inhibit lactation without medication. So it's important to also note that some persons living with HIV who give birth may face social, familial, and personal pressure to consider breastfeeding, despite the US recommendation to not breastfeed. And pressures may be high, especially if breastfeeding is considered really important to their culture. They may have fears that if they don't breastfeed and they start using formula, that people will know or think that they have HIV if they're not ready to reveal that. So it's important to discuss possible barriers to formula feeding during the pregnancy so that those things can be worked out. If you do have a person living with HIV who desires breastfeeding, you want to counsel them on the potential risks, but also if they are positive that they're just going to go ahead because they really want to. There are harm reduction approaches that can be used to decrease the risk. But again, it's not recommended in the US, but we also want our patients to be safe and to decrease the risk of transmission to infants. So if that's needed, then that should be a discussion between the birthing person and their provider. So everyone is at increased risk after birth. So there are some things that a birthing person should know, and their support people that are warning signs for after birth. So most people who give birth recover without problems, but any birthing person can have complications, such as I mentioned postpartum hemorrhage. But these postpartum complications don't differ for those with or without HIV. But they can be very serious. So learning to recognize these post-birth warning signs can save your life or someone else's. So it's a nice acronym to remember. Call 911 if you have one of the post: pain in the chest, obstructed breathing or shortness of breath, seizures, thoughts of hurting yourself or someone else. The pain in the chest and the obstructed breathing could be a blood clot that moves to the lung. Some Seizures could be a sign of eclampsia, which is a very serious perinatal disorder that can develop. And then thoughts of hurting yourself or someone else because there is an increased risk of postpartum depression or other perinatal disorders such as anxiety, very rarely, but it happens, psychosis. So you want to call 911 if you see these signs. Call the healthcare provider if there's birth, B-I-R-T-H, bleeding, so soaking through 1 pad an hour, or blood clots, a sign of an egg or bigger. That's sign of postpartum hemorrhage. An incision that's not healing, if they had a C-section or if they had to have a repair. Red or swollen leg, which could be a sign of a DVT or a deep vein thrombosis or blood clot in the leg. Temperature of 100.4, which could indicate, or higher, which could indicate an infection. And a headache that doesn't get better even after taking medicine, or a bad headache with vision changes. Again, that could be a sign of developing eclampsia or preeclampsia. So what you want to be prepared to tell 911 or the health care provider is the day of the infant was given birth and what the signs are. So I gave birth on June 2nd and I'm having pain in my chest. Trust your instincts. Always get medical care if you're not feeling well or if you have questions or concerns. So a little bit more about perinatal mood disorders. A number of studies have suggested that postpartum depression is common among women with HIV. And the U.S. Preventive Services Task Force recommends screening all postpartum women for postpartum depression using a validated tool. The most common one is the Edinburgh Postnatal Depression Scale. And what that screening will do is give the providers an idea of which patients might need more care. It's especially important for women living with HIV who appear to be at increased risk for postpartum depression, and also for poor adherence to the drug regimen during the postpartum period. Also, postpartum physical and psychological changes and the stressors of caring for a new baby may make adherence more difficult, and they may need additional support during this period. When pregnancy options are discussed, keep in mind that half of all women in the U.S. have an unplanned pregnancy at some point in their lives, and they have 3 options: to parent, to give birth and raise the child, to have an abortion by taking medication or having a medical procedure that ends the pregnancy, or adoption, giving birth and placing the child with another person or family permanently. So those are their rights. And couples who are affected by HIV have the right to receive assistance with reproduction. So if they're having difficulty conceiving, they also have the right to receive care. Evaluation and counseling should be provided to determine their eligibility for treatment. There's a risk of transmitting the virus to an uninfected partner through intercourse if the infected partner has undetectable viral load. So serodiscordant couples, so if one person has HIV and the other does not, they should be counseled on pre-exposure prophylaxis, which is when medication is given to actually prevent HIV, and it's taken daily, and it's highly effective. So that's something that's available and should be offered to couples. So let's talk a little bit about the challenges of pregnancy and living with HIV during a pandemic. Right now, we're all dealing with COVID-19. Coronaviruses are a large family of viruses that usually cause mild respiratory illnesses, such as common colds. So we have coronaviruses all around. If you see on a disinfectant that it says, this kills coronavirus, it's talking about like the common cold coronavirus, not what we're dealing with now. The virus that we're dealing with now is new. It's called SARS-CoV-2, and it is what causes the COVID-19. It was declared a pandemic in March by the World Health Organization. There are at least 6 other types of coronavirus, and 2 others have caused epidemics, SARS in 2002 and MERS in 2012. But this one was identified in humans before December 2019. It was not identified before 2019 in December, and it's thought to have originated in bats, and we call it COVID-19 for short. The symptoms, it affects the lungs and breathing. It's caused by this new virus, and it includes fever, cough, and trouble breathing, but it also may cause stomach issues, nausea and diarrhea, loss of sense of smell or taste, and the symptoms may appear 2 to 14 days after exposure to the virus. So if you have any of these symptoms, you want to call your healthcare provider and discuss with them whether or not you should come in for testing. The risk for coronavirus is increased in those who are over 60, those with other diseases such as diabetes, hypertension, heart disease, lung disease. They're all at high risk of COVID-19. Because it is a new disease, we have limited data available, but from what we have right now, it does not appear that the disease course of COVID-19 is different in those with HIV. So prevention. Before effective antiretroviral therapy was available, those with advanced HIV were at risk for complications of other respiratory infections. But we do not know if this is true for COVID-19. But we do know that other comorbidities can increase the risk, and smoking. So yet another reason to decrease smoking. But until more is known, additional cautions for all persons with HIV should be considered, especially for those with advanced HIV or poorly controlled HIV. Persons living with HIV should follow the recommendations for everyone. Wash your hands, stay 6 feet away from others when you're outdoors, wear a mask, and so forth. But in addition, they should maintain an adequate supply of their medication and all other medications, ideally 90-day supply, but definitely at least 30. They should get their vaccinations. They should social distance, and there's also more information about prevention during pregnancy. So, as I mentioned, they should have their medications. They should talk to their pharmacist or their provider to see about changing to mail order meds. And if the provider is planning a regimen switch, they may consider delaying the switch until they can have closer follow-up and monitoring if their in-person visits have been delayed. A little bit about medications for those who might want to know. Lopinavir and ritonavir have been used as off-label treatment for patients with COVID-19, and there are clinical trials underway, but it's not considered standard of care. If protease inhibitors are not already part of a person's regimen, they should not be changed to include a protease inhibitor to prevent or treat COVID-19. And all drug issues should be discussed with an HIV specialist. So during this time, a lot of providers are moving to telehealth, and they're decreasing clinic or lab visits. So the person living with HIV should discuss with their provider the risks and benefits of coming in person or not at this time, and they want to consider the extent of transmission locally, health needs that might need to be addressed, and that person's status, so their CD4 cell count and their viral load, and just their overall health. So the data does not indicate that pregnant individuals are more susceptible to COVID-19 or that they have a more significant illness for the pregnant individual. There have been some adverse outcomes for the infants, such as fetal distress and preterm delivery in a small series. So again, we don't have a lot of research and studies, but from what we do have, there has been some negative outcomes. They also have not found that there is evidence of transmission of the COVID-19 from the pregnant person to the infant in most studies, but there was one case that's been described. So more research needs to be done on that. So as I mentioned, there's not much of an effect, but the pregnant woman should avoid those who, just the general public, in order to avoid the infection as much as possible. And with the infant can get the virus once they've been born, if they're exposed to it. So also want to be very careful with those visiting the infant to make sure that they are washing hands, might wear a mask, and so forth. For prenatal care during this pandemic, again, the visits may change. Some OBGYNs and midwives are going on a limited schedule. So they're spacing out visits. They're doing some visits telehealth. So you want to talk to your provider about what would be best for you. Also, we want to talk about the mental health as it relates to COVID-19, right? This is a very stressful time. There are feelings of isolation and loneliness because of social distancing. And then you throw in the pregnancy and the possibility of postpartum depression, and those symptoms may worsen because of social distancing. So providers should share resources with the patients about coping with stress during COVID-19 and helping them come up with a plan to address the stress and the feelings of isolation. Like HIV, COVID-19 disproportionately hurts communities that are already marginalized and vulnerable due to white supremacy and structural systemic racism, homophobia, and misogyny. So now, with that in mind, I want to talk about the role of reproductive justice in HIV advocacy. Reproductive justice is the human right to maintain personal bodily autonomy, have children, not have children, and parent the children we have in safe and sustainable communities. And that definition is according to Sister Song Women of Color Reproductive Justice Collective. It's the first organization founded to build a reproductive justice movement. It emerged as a movement because women with low incomes, women of color, women with disabilities, LGBTQ+ people felt marginalized in the reproductive rights movement of the 70s, which focused primarily on pro-choice versus pro-life. But this framework acknowledges the fact that there are intersecting factors, such as race and class, that impact marginalized groups of women differently. And this means that not every woman or birthing person has the freedom to choose what they want for their pregnancy when their options are limited by oppressive circumstances or lack of access to services. So reproductive justice movement was created to address how race, gender, class, ability, nationality, sexuality, and what I would say, HIV status, where all of those connect. So reproductive politics is not about choice. It's about justice. And again, those three core values: the right to have a child, the right to not have a child, and the right to parent a child or children in safe and healthy environments. And things to be considered for those living with HIV. You want to look at access to HIV prevention and healthcare, support for building families. There are issues surrounding criminalization of HIV and policing of sexuality, and also discrimination and stigma. One other issue is sterilizations. The beginning of the birth control movement in the US alienated Black women in many ways, while mostly the white leadership advocates in this movement catered mainly to the needs of white women. Additionally, in the early 20th century, white nationalists spread the concept of race suicide. They spread this fear that white women using birth control would reduce the number of white babies born, thus limiting the power and control of white people in the US. So this concept has been complemented by a history of forced and coerced sterilization of women of color around the world, but including in the US. The most recent cases of non-consensual sterilization in the US occurred throughout the 20th century, targeting women with HIV, women who are ethnic and racial minorities, and women with disabilities, and poor women, amongst others. There's also a concern during COVID-19 of reproductive coercion. There's a concern for increase in forced pregnancies and reproductive control. During this crisis, the state governments have restricted abortion care, citing the coronavirus precautions in order to ban or block the availability of abortion services. And they do this by labeling the surgical procedure as elective and non-essential. So then those who need services cannot get them. While most abortion bans have been lifted as states reopen and as litigation, court procedures occur, Arkansas is requiring abortion seekers to first get a negative COVID-19 test within 48 hours of the procedure before they can get it done. So it's another hurdle. Racial disparities in perinatal health. There's a lot of discussion currently about this, and it's also something you want to keep in mind because it affects those who are living with HIV disproportionately. African Americans are 3 to 4 times more likely to be born with low birth weight than whites, and that increases their risk for developmental disorders. African American women are 3 to 4 times more likely to die from pregnancy-related deaths. They have lower breastfeeding rates versus whites, and in Philadelphia, maternal mortality rate is 53% higher than the national average, and the infant mortality rate for African Americans is 13.9 per 1,000 births, while 5.1 for whites. So there's a clear disparity. Also, we want to think about racial injustices and inequities that occur outside of pregnancy because those still intersect. Right, so police violence is still a reproductive justice issue because when you consider whether or not you are going to bring a child into this world, you have to consider whether or not you can keep them safe. So what is going on with police brutality is very relevant, and it is something that we should address. With the protests and uprisings, also, I wanted to note that there are increased risks that should be considered for anyone who is pregnant because of the use of tear gas and violence. There can be trauma and stress, which can increase perinatal depression. So just real quickly, I want to go through what tear gas is because I've heard some things about it as it relates to pregnancy. Tear gas affects the mucous membrane, so it feels like burning in the eyes, the nose, the throat, the skin. It can cause vomiting and coughing. It's considered non-lethal, but in some instances, for instance, one woman had asthma. It can be very dangerous for people who have respiratory diseases, for babies, for the elderly, for people who are immunocompromised. There are some anecdotal reports from various countries that claim a correlation between frequent and prolonged exposure to tear gas and miscarriage, but there's no studies that have supported these findings. And an organization called the Physicians for Human Rights did some research and could not find substantiating evidence to make a strong claim that it does cause miscarriages. But we still want to consider the trauma and stress that comes with that. So one area that I want to bring up for reproductive justice and how we can mitigate the inequalities and issues that persons living with HIV and persons of color deal with is the use of doulas. So what is a doula? They are a person trained to provide non-medical, emotional, physical, and informational support during pregnancy, childbirth, and or the postpartum period. Some people call them labor support persons or labor coaches. And they actually have research studies that show a reduced length of labor and also use of obstetric interventions, including pain meds, decreased C-section rates, and increase in bonding between the birthing person and their infant, amongst others. So those are actually evidence-based resource. Okay, and wrapping up, what can you do? So you can volunteer as an advocate for persons living with HIV to help protect their rights in pregnancy, childbirth, and postpartum period. You can raise money to help those who have limited resources so that they can afford services. You can talk to your own provider and see if they are LGBTQ friendly and what they do, what services they provide, what education they've gained for themselves to be able to provide these services. You can encourage the use of culturally sensitive providers, midwives, and doulas who are well informed about how to support persons living with HIV, and educate your friends, family, and peers about these issues. I just wanted to leave you with some resources. These are great organizations, starting with Philadelphia Fight. That's their website. They provide a lot of services through their women's health program, support groups, just various resources. The Health Federation of Philadelphia is another organization that provides services. Action Wellness, great for case management as well as other services. The AIDS Activities Coordinating Offices has a helpline. They also do some great work. One particular project that I've been following is the Perinatal HIV Prevention Project. It's actually a collaboration between the Health Federation, Action Wellness, and AACO. Try to Google that if you can and learn more about the services that they provide in order to prevent perinatal transmission. And then lastly, there are a whole bunch of resources, but these are my top. Lastly, Maternity Care Coalition. They provide doula services for those who have less means. They're a great resource for any pregnant person, but I would love to see an increase in the number of those persons living with HIV, getting the support that they need during pregnancy and birth and postpartum. Because if we all join in, we can ensure that those who are pregnant and living with HIV have more support, and because they have more support, they have better outcomes. So with that, I want to thank you and see if anybody has any questions for me.
Dr. Peterson, thank you, thank you, thank you. I have to admit, I was sitting here figuring out how to summarize your presentation, and all I could come up with was a theme which is HIV and pregnancy and all things relevant, all the intersecting topics that you presented that's relevant to HIV and pregnancy. So thank you for such a thorough presentation. There were two things that stood out to me. I think the beginning, where you kind of briefly did an HIV one-on-one. I think all too often as providers and those of us who work in the field of HIV, we forget that there are many people who have no understanding of HIV 101, even in 2020. And so I appreciate you just going over this, the basics for those who are on this webinar who really are unfamiliar, but also when you end it with the call of action. And so I appreciate that, because it's not enough just to know, but now that we know, what will we do with this information that we have, right?
Absolutely.
Get that information back to be a change agent. So I appreciate everything. I mean, I was trying to take notes. I said, there's no way I'm gonna summarize all of this because you covered so much, from COVID to racial justice to, I mean, it was just so much. So I appreciate your thorough knowledge and just kind of planting the seeds of things that intersect this topic. So with that, I'm gonna go right into the questions. So some of these questions you probably answered, but I'm gonna ask them anyway because they were posted in the Q&A box. So one of the questions was speaking to the breastfeeding you spoke to. And so the question was, can you speak to breastfeeding recommendations in light of U equals U? Oh no, did we lose Dr. Peterson? Hold on, let's see. I think we lost her. She may log back in. Give us a moment. You know, with technology, anything is possible to happen. Here she goes. Dr. Peterson?
Okay, sorry about that.
Yeah.
Don't know what happened.
That's okay. So I don't know if you caught the question, but I'm going to ask the question again.
Okay.
As I was saying before we lost you, is that some of these things you may have answered, but I'm going to ask them anyway.
Okay.
It's going to be like a refresher. So one question was, can you speak to breastfeeding recommendations in light of U equals U?
Can you say that last line one more time? In light of?
Can you speak to breastfeeding recommendations in light of U equals U?
So here in the US, as I mentioned, it's not recommended. Even if the viral load is undetectable, really low, there's still a possibility of transmitting. But that can be a discussion that the birthing person can have with their provider about their comfort level, their risks and benefits. I would say that's an individual decision for them. You know, the recommendation again from the CDC is to not breastfeed, but that is an individual answer. I can't and wouldn't answer that for anyone. Yeah, just discuss that with their provider, I would always recommend.
Okay, thank you. The next question is, you stated that there were only 5 infants born with HIV in Philadelphia between the period of 2011 and 2015. Has this rate lowered in the past 5 years?
Yes. Was that a question?
Yes. Has this rate lowered in the past 5 years?
You know, I didn't have that data. I would hope so, but I do not know specifically if since 2015, if there has been a decrease.
Okay. The next question, it says, by oxytocin, do you mean Pitocin? I think I may have mispronounced that medication, the artificial version.
Yes. So that would be, so the generic name is oxytocin, and the brand name is Pitocin. Oxytocin is actually a hormone that is in our bodies, that is produced by our bodies. And it does a couple of things. It helps with the letdown or the release of breast milk for those who are breastfeeding. But during labor, the presence of oxytocin actually causes the contractions in the uterus. And so sometimes if someone is in labor and their labor, like their contractions slow down, they get to 4 or 5 centimeters and they just get stuck there for hours. Usually doctors won't let you go that long, but they will recommend the Pitocin or oxytocin to be given through an IV to increase the contractions, with the idea that it will allow the birth to progress and they won't get stuck. So with someone who is living with HIV, and if their membranes rupture, so their water breaks, but their contractions, sometimes your waters can break and the contractions don't start right away. But you want the labor to progress in order to decrease the risk of transmission of HIV. So you can give the medication, Pitocin or oxytocin, in order to get those contractions started.
Okay. Thank you for that thorough answer. So we have we have about 7 questions remaining. So one of the questions, it was specific to children who are not on ART. So the question is, are those prognoses that you mentioned in the presentation only for children not on ART?
Yes, yes, that prognosis was for children not on ART.
Okay. The next question is, you know if there are any milk bank options in PA specifically for people living with HIV?
That is a great question. I have not heard of any that are specifically catering to those living with HIV. Wow, not to my knowledge, but I am definitely going to look into that to see if, I doubt if there are any here, but I am curious to know if there are any in the US. I just haven't heard of it. Yeah, but
Okay.
you can use any milk bank. It doesn't have to, it's just, it can be rare that it's available. It can be difficult, but they are increasing more and more, and so the availability is increasing.
Okay.
But we do need more services that can provide that, and I think that's an area of advocacy that hasn't been touched enough. So that was a great question.
Okay. Next question is, it was mentioned that U equals U, but closer to the end of the talk, it was commented on even if undetectable, there is still a risk of transmission to a partner?
Yes, yes, because of the latency of the cells. You can have undetectable viral loads, but it can still resurface. And so you still want to protect your partner.
So question, so a clarifying question, is this specific to when you're pregnant that this would apply, or is this in general, if as U equals U, you're saying it's still a risk of transmission?
I was talking about in pregnancy.
In pregnancy.
Yeah. Again, I think that would be something that the individual should talk to their provider about based on their overall health.
Okay. So that question is completed. The next question is there any research happening about breastfeeding and U equals U? It seems really important. I think you may have answered this question already.
Mm-hmm. Yeah. Yeah, according to what we know, it can still be passed above certain levels But I don't think there's research. I haven't seen any research for U equals U and breastfeeding. But in the US, they still just recommend not to take that chance.
Okay. So the next question. No perinatal transmission in 2016, 17, 18, and 19. So it was a comment. They were excited about the
wonderful
transmission. Yes, that is great news.
It's wonderful.
That's awesome news. Yeah.
Yeah, absolutely.
Hope who are seeking to have a child who are HIV positive. That's great. Next question is, can you be denied HIV tests during pregnancy across states?
Can you be denied
HIV tests during pregnancy? And then the next kind of question is across states. So I guess they want to know if you could be denied testing here in Philadelphia, but also across the states while pregnant.
No. You should not. Like, if someone is pregnant, they should be offered an HIV test. They can opt out. But no, they should absolutely be offered an HIV test. And if they are pregnant and they are denied an HIV test, that to me would have legal ramifications. Yeah. Has that happened to someone?
Well, I guess the person who posted the question clarified it and says, I meant can someone deny the test? I guess it's kind of.
Yes. Okay. Yes, you can opt out. You can opt out. Absolutely. That is that person's choice. They might not be informed though. So that is something that I would say as a consumer or a pregnant person going into your provider's office, if you know that should your pregnancy test come up positive, or if you already know that you're pregnant and this is your first visit and you do not want to be tested, that is something you should state. Ideally, providers show you a list of all the tests that they're gonna do, right? But that oftentimes doesn't happen. They just say, okay, this is your first visit, we're gonna do some blood tests, right? So if you know that you do not want to be tested, then you state that and you have that option. That is your legal right to opt out.
Okay. You have two questions left. One asks, doesn't Pitocin increase the likelihood of birth interventions?
Yes. Yes, it does. And so in that situation, you want to consider the risks and benefits. So Pitocin can increase the risk of interventions, but if you, for instance, in the situation that I mentioned, if someone living with HIV, their water breaks, we know that that increases the risk of transmission of HIV. And so knowing that, we want to decrease the time of labor. And so you have to weigh the risks and benefits. And that is something for that individual to discuss with their provider. If they do not want, if they are, against using the oxytocin, then that's something they should talk with their provider about. There's also a trial. You can do a trial of oxytocin, right? And say, I want to try it, but I definitely do not want a C-section. But also understanding that it can increase your risk of getting there. And that can be something that can be closely monitored with your provider.
Okay, thank you. And your last question is, have you heard anything about HIV vaccine?
The HIV vaccine, the one that the president was referring to? Is that what we're talking about?
I don't know. It just asks, have you heard anything about HIV vaccine?
That is the only thing that I have heard. And No, there is no HIV vaccine available. He misspoke when he said that. And I wanted to be very clear that if there is one in, I know that there are people working on one, labs all over the country that are trying to develop an HIV vaccine. If it has been found, I am unaware of it, but I do know that it's not available on the CDC website. It specifically states, and I checked it right after he made that announcement, because I was like, I've never heard that before. It says that there is no HIV vaccine available.
Great. So that concludes our Q&A. Dr. Peterson, I want to thank you so much for your sharing your knowledge and your expertise about this topic of HIV and pregnancy and all of the intersecting topics you covered. So thank you for your presentation. And for those of you who had joined us today for today's webinar, please hang tight. Once our webinar ends, you will be prompted to complete a survey. So please complete the survey, give us your feedback and your thoughts about today's presentation. Your voice matters to help us improve our webinar services to you in the community. So we thank you for joining us today. Thank you, Dr. Peterson.
Oh, thank you. Thank you.
Have a great day and thank you for joining us. Take care.